I'm really delighted to join you this afternoon in this meeting to present to you about iron deficiency anemia in Sub-Saharan Africa. And this is really a call to action because as Professor Julie already explained, most of the evidence really on the table. It's now how we translate it to practice. Now, our paper is part of the Lancet Haematology Series, Priorities in Hematological Care in Sub-Saharan Africa, which is being launched today. So this is also another exciting moment for us. My name is Martin Mwangi, and I'm a nutritional epidemiologist, senior research fellow based at the Training and Research Unit of Excellence at the College of Medicine in University of Malawi. We wrote this paper with my fellow co-authors as listed, and I'm really presenting on their behalf, and I also want to thank them for working with us on this. We sought to review the causes, burden, and consequences of iron deficiency anemia in the general population of Sub-Saharan Africa. And we also sought to review the current policies and interventions for the control of iron deficiency anemia in the general population of Sub-Saharan Africa, and then present the evidence and also see where the continent or the region could do better. And so I start by presenting to you the epidemiology of iron deficiency anemia in Sub-Saharan Africa. This is based on the most recent data that have been published by the World Health Organization about the region. And to say the least, the anemia prevalence in various population groups, preschool age children, pregnant women, non-pregnant women, it's saddening compared to the rest other regions in the world. So among preschool age children, reading from the table at the top, 67.6% of preschool children have anemia, and this translates to around 83.5 million infected children. And when you look at pregnant women, 57% of pregnant women have anemia, and this translates roughly to 72.2 million pregnant women. And in the soon-to-be or the future mothers, that's the non-pregnant women, 47.5% of this population is anemic, and this translates roughly to 70 million individuals or non-pregnant women living with anemia. And if you look at the map on my lower left of the screen, you can see that Sub-Saharan Africa really has the bulk of the burden of anemia globally. And the reasons are multiple. As we all know, the causes of anemia are multiple. But really, in the region, the determinants of anemia are mainly as a result of diet. We know that most diets are monotonous and plant-based, with a lot of anti-nutrient factors such as phytates. And since most bioavailable iron is actually from animal source foods, this predisposes the populations to anemia. We also have a number of infectious diseases and also for example, worms like hookworms that are still prevalent in some certain regions in the of Sub-Saharan Africa. Malaria endemicity is also a challenge. This is also a subtropical zone that is still struggling with a lot of malaria. And then, as has already been highlighted by previous speakers, the genetic background of populations in Sub-Saharan Africa sometimes predisposes us to higher prevalences of anemia. Our health systems, luckily, as Professor Julie has already said, are there, but they need serious strengthening to be able to cope with the prevalences of anemia as highlighted above. In addition to that, we have barriers to scaling up iron interventions. And notably, when you scale up, for example, iron supplementation in children, you are worried that you might cause more malaria based on evidence. And therefore, we noted during our search, our literature search, that various countries or various population groups are not being covered because of certain conflicting policies. In addition to that, we have this region experiencing a rapid population growth. And soon we are going to, the next couple of years, we're going to surpass a number of regions when it comes to the population as highlighted above. So we're going to be a region of about 3.1 billion people. And that means the problem of dealing with anemia is just going to be worse if we don't do anything now. So in our literature search, in our writing, in our analysis, we came up with 7 core key messages that need to go out urgently to call to action various stakeholders to intervene so that we can bring, control the challenge of iron-deficiency anemia in the region of Sub-Saharan Africa. The first message directed at pregnant women is really about adherence. And this is adherence to iron supplementation during pregnancy, which now we know, we have evidence that if there is proper adherence, this is likely to lead to substantial reduction in postpartum hemorrhage-induced maternal mortality and to increased birth weight of the newborns. We know that the mother-to-be generation in Africa, in Sub-Saharan Africa, and especially pregnant women currently go into pregnancy with inadequate stores. Yet this is compounded by the fact that they have low iron intake, as I already explained. And yet this is a period of pregnancy, is a period where there is high iron requirements. What we end up seeing is increased maternal mortality, postpartum hemorrhage, prematurity of the newborns, and a low birth weight of the newborns, thereby leading to them being unable to survive the first 1,000 days. And there is now mounting evidence that this also has an effect on the future brain development of the newborns. In later life, when the children are growing, there is now evidence that the diets are in terms of complementary foods are iron poor, and these children are also growing in environments with a lot of inflammation, and we now know that inflammation also causes iron absorption to be affected. This impacts on the growth of these children, and this seems to be a vicious cycle because over time this become adolescents, and the females go on to become pregnant, and the cycle is repeated, and it has to be arrested at some point. The second key message is also directed to pregnant women, but this time around, it's about the national programs in various countries in Sub-Saharan Africa. These national programs for antenatal iron supplementation urgently need strengthening, and some of them actually need overhauling, and almost all of them require international financial and technical support if they are going to be able to improve delivery and create demand for their services. And this is the backdrop to this is that we now have seen that iron supplementation works. But how do you deliver iron supplements to pregnant women at the right time, to all populations in such a vast region? Africa is huge, and governments are struggling to cope in terms of national programs. The other key message is directed to children. And these are 2 messages, message 3 and 4. The first one is actually in line with the World Health Organization recommendations that iron intervention should not be given to children in malaria endemic areas unless we give them in conjunction with measures to prevent malaria. And this is really to protect the children from, getting more sick from malaria and possibly even dying. Now, the new thing that we are calling for here is that when you give iron interventions to these children, this should be administered to individual recipients of iron interventions, rather than giving them in mass to the general public. And usually when governments or when national programs do this kind of interventions, it's very difficult to do, assess whether you have, malaria, and also then treat. It's very difficult because of lack of resources, because of inadequate programs, challenges of reach, and therefore we tend to see that populations or rather national programs tend to prioritize mass interventions. The other key message is on delayed cord clamping. There is now good evidence that cord clamping actually can prevent or delay the onset of iron-deficiency anemia in late infancy, when children are most susceptible. And therefore, we call for this to be scaled up, if not being scaled up, and standardized in most countries so that we have newborns benefiting from this. The other key message 5 is directed at adolescent girls and non-pregnant women. Sufficient iron stores should be attained before pregnancy or between pregnancies to prevent iron deficiency and anemia during pregnancy. But we noted that insufficient attention is given in research and policies to adolescent girls, perhaps on the grounds that iron deficiency anemia is relatively uncommon in this group. Now, if you look at the graph that I've put there, in terms of growth in vis-a-vis the human life cycle, iron is required in all stages of growth from infancy, child, adolescent, all the way to old age. But what you want is a prime adult who has the sufficient iron stores to go on to couple up and probably go on to have a child who is also going to grow into a young person, adolescent, who is capable of becoming another prime adult. We have to aim to be getting at and stays in our prime as far as iron supplementation is concerned. For adolescent girls, policies should be reviewed to give women of reproductive age, including adolescent girls, access to contraceptives with a specific aim of controlling menstrual bleeding and its associated anemia and to building iron stores. We noted that adolescent girls and access to contraceptives is a bit of an unrecognized intervention point. There are very few policies directed at this population, and hence the reason why we call for this focus to be redirected to adolescent girls and non-pregnant women. Finally, a general key message is that effective control of infections, especially in Sub-Saharan Africa, is required to improve iron absorption and utilization and to make iron intervention safe and more efficacious. This is the backdrop of the hepcidin evidence that has come in the recent years, but also with the mounting evidence that if you control hookworm infestations and other infections, then iron absorption is improved, and therefore, again, programs for effective control of infections should be scaled up. In summary, the first one is that adherence to iron supplementation in pregnancy leads to reductions in postpartum hemorrhage, hemorrhage-induced maternal mortality, and increased birth weight. Cord clamping, if we adhere to cord clamping, this will prevent or delay the onset of iron deficiency anemia in late infancy. Helminth control is a safe way to prevent iron loss in school-age children, aged 5 to 18 years old, and adults also. Effective control of infections is required to improve iron absorption and utilization and to make iron interventions safe and more efficacious. Now, the low coverage, lack of coordinated action, and the low priority currently given to antenatal iron supplementation in Sub-Saharan Africa is simply unacceptable. And we need to have a mind shift. National programs need to be reorganized in how to tackle this problem of antenatal iron supplementation. Probably new intervention, novel methods like IV iron, for example, need to be tested. Administering malaria preventive measures to individual recipients of iron interventions is ethically required in place of public malaria control measures that might not reach these individuals. Finally, policies should be reviewed with the aim of giving women of reproductive age, including adolescent girls, access to contraceptives with the specific purpose of controlling menstrual bleeding and its associated anemia. With that, I would like to thank everybody, especially the Lancet Haematology, for providing this platform and also for launching. And also invite you to read a lot more information in the paper as is shown in that picture, where you will be able to understand, or rather to process more the points I have just highlighted. Thank you very much.